At the time the diagnosis of brain metastases or new tumors in the brain is made, it's important that the treatment team take into account the patient's situation in regard to the tumor outside the brain. Some patients will have had no sign of the tumor growing for many months or many years, and the growth in the brain will represent a new phase in their treatment. Other patients may be undergoing active treatment for the tumor either at its original site or at other areas in the body where it's spread. As I'll explain in the coming few minutes, the treatment for the tumor in the brain may be different than the treatment for the tumor elsewhere in the body, and you can expect that you may have one treatment strategy for the brain component and a different treatment strategy for the tumor elsewhere in the body. And it may even be someone like me, a neurosurgeon, is guiding the brain component and is partnered with a medical oncologist who is guiding the treatment of the tumor outside the brain. The important thing is that these two members of your team or multiple members of your team are in constant communication so that the treatment is the best treatment for your entire tumor and not just the tumor in one site. It's very important at the time the brain metastases are discovered that you and your treatment team talk about all of the treatment options. I always think my role as a doctor with an interest in brain metastases is to explain all of the options with the advantages and disadvantages of each, and then to give the patient a particular recommendation of one or two or three of the options that appear medically perhaps to have a higher success rate. Let's talk for a minute about what the different treatment options are. Essentially, I think there's 5. One is to watch. In certain patients, we'll find a very small dot of what might be a tumor, and we may decide that the best thing to do is to do very close follow-up. This isn't often the case, but it certainly should be considered for every patient. I wouldn't use that for a patient with a large tumor who has a lot of symptoms from their tumor or for whom we need a diagnosis. But in some of my patients, the amount of tumor that's there is very small, and close follow-up may be an observation, may be a good option. The second option is surgical removal. You may think as a neurosurgeon that we recommend surgery for everybody. And surgery is a good option for a subset of patients, but it has to be very closely personalized. The patients who usually would go for surgery are ones who have 1 or maybe 2 tumors rather than many tumors, and for whom one of those tumors is causing a lot of symptoms. So a large tumor that was causing speech trouble or weakness could be removed, the tumor could be treated, and the symptoms could improve. That would be an outstanding or an excellent time to recommend surgery. Other patients have multiple tumors or tumors in unfavorable locations, and we would probably use other treatments besides surgery to treat those. Surgery should be considered, but often there'll be other less invasive methods that can be used. There are 2 forms of radiation that are used to treat brain tumors, and they're slightly different in how they're done and in the types of tumors that they use. I'd like to spend a moment and explain the 2 of them, and then try to put them in context in terms of which patients might benefit from one or the other. One type of treatment is called stereotactic radiosurgery. It's a big word. What it talks about is very focused radiation. There are 2 machines that do this the most, called the Gamma knife and the Cyber knife. They're sort of like the Coke and Pepsi. They're the most common forms, but there are many companies that make machines that do radiosurgery, and they're all pretty effective in treating this. I rarely find that the key issue is deciding which brand of machine to use. I find it's much more important to decide whether focused radiation, this radiosurgery that I'll explain in a moment, is the right treatment or not. The other kind of treatment is called whole brain radiation. The major difference between radiosurgery and whole brain radiation is how big the target is and how many treatments are given. So radiosurgery is a very precise treatment. I ask my patients to think of a bicycle tire and to think of every spoke on the bicycle tire as a beam of radiation. The axle, which sits in the middle, would get a big dose of radiation because every beam intersects it. But the rest of the brain, which is the rest of the tire, will get very little radiation because there's just a thin line here and a thin line here. Radiosurgery is a very precise treatment of a single tumor, and it's very effective at treating that tumor, but it does not provide protection elsewhere in the brain because all of the radiation is focused on that one spot, the axle of the tire. Whole brain radiation is almost the opposite. The entire brain, the whole brain, is treated with radiation. This is usually spread out over 2 or 3 or even 4 weeks. and that allows the normal brain to tolerate the radiation. The radiosurgery is usually given on a single day, occasionally on 2 or 3 days, but it's very targeted. So let's just summarize those two things. Radiosurgery treats a single tumor in a single day, and it works very well for 1 or 2 or maybe 3 tumors. Whole brain treats the entire brain, and so if there are multiple tumors, 10 or 20, it will treat all of those tumors. Whole brain can also treat tiny little seeds of tumor that are too small for me as a doctor to see on MRI. Sometimes we give both. We give radiosurgery to treat the tumor we can see, and we give whole brain to protect from other tumors. The decision to choose between these two types of radiation or use them together really requires you sitting down with a radiation oncologist and often a neurosurgeon who does radiosurgery and deciding in your particular case what's the ideal strategy to control the brain. Some people worry about giving radiation to the brain and potential side effects, but I always try to remind them that the thing that worries me most is tumor growing in the brain, and that successfully treating the tumor in the brain is usually the best way to make sure that the patient feels well and maintains a high quality of life. Very often the tumor that a patient is diagnosed with, the lung tumor, the breast tumor, the melanoma, is being treated with chemotherapy. And patients ask, why can't the chemotherapy be used to treat the tumor in the brain? After all, it's the same tumor, it's just spread to a new place. The answer is, sometimes it can. The problem is that the human body has walled the brain off with something called the blood-brain barrier. I always think that that was put there so that if we happen to eat a bad mushroom, it might keep that toxin from getting into our brain, but can also prevent chemotherapies that are given as pills or given as infusions from getting into the brain. And so the tumor cells can, in a sense, hide behind the blood-brain barrier. It may be hard to reach them. Whatever chemotherapy is proposed to treat the brain tumor, the medical oncologist who's to give that chemotherapy needs to make sure that that particular drug can cross the blood-brain barrier. Some can and some can't. It obviously would make no sense to treat a tumor inside the brain with a drug that doesn't cross the blood-brain barrier. And this is why you may find that you're getting one chemotherapy to treat the tumor everywhere in your brain, and then getting radiosurgery or whole brain radiation to treat the tumor in the brain, because the brain can't be treated with the chemotherapy drug. Other times the drug will work in the brain, and it may be that all of the tumor everywhere in the body can be treated with a single drug. Obviously that would be ideal, but unfortunately it doesn't always happen.